Right, we're going to look at comfort, rest, and sleep today and how important it is. So, to be comfortable, we want to be without physical or emotional discomfort or distress in any way. Because comfort, rest, and sleep problems, they're going to affect our entire life. They're going to affect our patient. They're going to affect their physical well-being, their emotional well-being, their spiritual well-being. So when we talk about discomfort or pain, it can be physical, it can be emotional. They're both going to impact us, but it's going to impact our ability to feel good. And that's going to decrease our function and quality of life. So rest and sleep, they restore energy, they restore our sense of well-being. So they're exceptionally important for good health. So when we talk about comfort, it's a state of well-being. You're not having any physical pain, you're not having any emotional pain. And it doesn't even necessarily mean you have to be happy, but you're not having any distress of any kind, physical or emotional. So it's impacted by age, by illness, and by your activity. It can also be impacted by temperature. If you're too hot, it's hard to feel good. It's hard to feel comfortable. If you're too cold, ventilation. If the air doesn't smell good, if there's odors, or if there's excessive noises, it's not going to make you feel comfortable. It's not going to give you a sense of peace. Lighting, okay, I mean, bright lights are usually wake people up. Soft lights are a little bit easier on people for resting. So lighting can impact how well you rest as well. The term pain or discomfort means to ache, to hurt, or to be sore. So comfort and discomfort are subjective. So we've talked about objective data and subjective data. Objective data, what you're seeing, what you hear, what you smell, what you touch. Subjective data, what the patient is telling you. And you have to rely on what the patient says. Pain is personal. And so you can't decide, oh, gee, I think that person's just making that up. I think they're just looking for pain medication. Pain is a warning from the body. And if a person's feeling pain, we need to assume that they are having pain, and we need to make sure that we let the nurse know. And then we can provide comfort measures for them. It is considered a vital sign. So when we learned our vital signs, we said we're going to take temperature, we're going to take pulse, we're going to take respirations, and we are going blood pressure, and we're going to ask pain level. So there are different types of pain. There is acute pain, and acute pain means it comes on suddenly. It's sharp, it's stabbing, however they describe it, it comes on suddenly. They were fine, and then boom, they have pain. Chronic pain is a problem that the person has had for at least 3 months or more. Usually between at least 3 and 6 months, they've had a chronic issue with their lower back. They've had chronic knee problems. They have chronic arthritis problems. So it's a type of pain that they generally have been having for a long extended period of time. Radiating pain is pain that is felt at the site of the tissue damage, and it travels to nearby areas. So let's say the person is having pain in their chest, and it travels up their neck, it travels down their arms, it travels through to their back. That would be radiating pain. Referred pain is pain felt in a different part of the body. So maybe they're having pain, the problem is in one area, but they're actually feeling it in another area. And then phantom pain is felt in a body part that's no longer there. And that's very common, especially the first year after a amputated extremity, an amputated leg, that people still feel like their leg is there. They're still complaining of pain to their leg. And they realize it's been amputated. Okay, they're not crazy. Okay, but it is still real pain for them. So things that can impact your pain is your past experience. So let's say you get a headache and you take 2 Tylenol and your headache goes away in a half hour to an hour. Next time you feel a headache coming on, you're not really going to think that much of it. You're going to think, okay, I'm getting a headache. I'll take a couple Tylenol. Big deal. Okay. But if you have a headache and they tend to turn into migraines and you get sick to your stomach with them and you can barely function with them because the pain is so intense, when you start feeling a headache coming on, you're going to have a totally different thought process with that headache coming on. Okay. You're going to think completely different. Anxiety. If you're anxious about something, if you're really stressed, remember anxiety is that uneasy feeling to stressors. So if you're feeling stress over something and you're anxious about it, It's going to impact how you feel about pain. It's going to impact your pain levels. Rest and sleep. If you've had a good night's sleep, you can deal with a lot more the next day, pain or no pain, than you can when you haven't had any sleep. When you haven't had any sleep and you're feeling tired and you're feeling run down and then you get pain, it's almost overwhelming sometimes. Attention to it. So one thing that we're going to recommend when people are having pain is we're going to recommend that you try distraction techniques. See if you can read a book to them. See if you can get them to watch TV. If they have visitors, that's great. Okay, it can take their mind off of it, because when you focus on it, you tend to think about it more and it becomes more intense. So for instance, you can have a patient that's complaining of pain, and you're like, okay, I'll go tell the nurse, and you come back and say, okay, it's not really even time for pain medication yet. You see that they're visiting with their family and they're laughing and talking, and you're like, oh, he's not really having pain. He's just making it up. Well, no, they probably are having pain. It's just distracting it by still communicating with other people, being able to talk or laugh or watch TV, taking your mind off of it. You don't just focus and dwell on it. If you've ever had a really bad headache, okay, especially if you have kids, like you wake up, you have a really bad headache, it's not like you can just quit being a parent when you're tired and you don't feel good and you have a headache. So you still have to get up and get your kids ready for school. You still have to get up and get them breakfast. You still have to do this and do that. And so you're still just going. And sometimes you'll crawl in bed that night and it's like, God, my head is still killing me. But you weren't thinking about it all day because you were distracted. It doesn't mean it's not real pain. Personal and family duties. So again, you got kids, who gets a day off? I mean, really, I love those commercials for NyQuil when the parent goes in and says, you know, their kid's in the crib and they're like, I'm going to take the day off tomorrow. It's like, yeah, right, like that ever happens when you're a parent. Culture. Some cultures believe in being very stoic with pain, where it's not proper to show emotion when you're having pain, that you should be able to overcome your pain on your own. You shouldn't have to take pain medication. You should not be vocal about your pain. And some cultures, it's like the more you yell, the more you scream, the better off it is. So you're going to see different extremes in culture. Illness, okay? If you have other illnesses going on, pain is even more magnified generally. And age is going to impact pain as well and how a person deals with it. So when a person is complaining of pain, one thing that you want to do is you should always know the location of pain. So you go into your resident's room and they are complaining of pain. Where? You should always know where it is. I cannot tell you how many CNAs I've had come up to me and say, Kelly, you know, Mrs. Smith, she's complaining of pain. Well, where's her pain? Well, I don't know. Well, how bad is her pain? I don't know. Seriously? When a person is complaining of pain, you should always find out where it is, okay? And we're always going to put it on a pain scale value. So our pain scale, we use a numeric pain scale. It is from 0 to 10. 0 being no pain, 10 being the worst pain you could possibly imagine. Where would you rate that pain? We don't really like to use the terms mild or moderate or severe, because what I would describe as mild pain might be something different, might be moderate pain to someone else. Those are very difficult terms to try to gauge if the pain is getting better, if the pain is getting worse. So we usually want to use it on a numeric scale of that 0 to 10. Now, other things that generally the nurse will assess for is the onset of the pain, the duration of it. How would they describe it? Is it stabbing? Is it coming and going? Is it intermittent? Is it dull and achy? I mean, how would they describe that pain? Are there things that cause the pain, or are there things that make that pain better or make it worse? What are the vital signs with the pain? And are there any other signs or symptoms? Are they nauseated with the pain? Is the pain radiating? Is it traveling somewhere else? You know, we would get as much information about that pain as possible. Now, as a CNA, truthfully, I expect my CNAs to know location and intensity of pain. Now, these other things, not a bad habit to get into of learning how to do that, especially if you're planning on going on in your nursing career, of finding out the onset of things that make it better, things that make it worse. But you should, at a minimum, as a CNA, know your location and your intensity. So this is that pain scale. So 0 is no pain, 10 being the worst pain a person could possibly imagine. Where would they rate it? And the reason why we want to know that, so if the person says the pain level is a 4, okay, and now let's say the nurse goes in and gives them pain medication that was ordered, and then a half hour later it's a 2. Well, I know I'm going in the right direction. But if it was a 4 and I give pain medication and now it's a 6, I know this pain medication isn't working for this person. So we always kind of want to put it on that scale so we can kind of gauge how we're doing with our pain. The Wong-Baker Faces Rating Scale is for people who can't talk or for little kids. They can either point to the face that they feel, or sometimes you may have to gauge it off of what you're seeing. Now, there are also some nursing measures. So when a person has pain, okay, when a person is complaining of pain to you, you need to go let the nurse know. You want to go tell the nurse, because the longer it goes on, the more intense that pain is going to be. So let's say you're going around and you're taking vital signs on all your residents, and someone tells you that they're having pain. Just swing by the nurse's station and say, hey, Mrs. So-and-so is having pain. So that, and then you can continue your vital signs. But you want to make sure that, the longer you make them wait, if you go take all your vital signs before you go tell the nurse, another half hour, another hour is going to go by? That pain that was a 4 is probably going to be a 5 or a 6 now. It's going to be harder to control. So we want to let the nurse know. Now, after we let the nurse know, we want to go back to the patient, tell them that, hey, we told the nurse, okay? And then we want to try some of these other nursing measures to make them feel more comfortable. Distraction, okay? Relaxation. Are your sheets comfortable for you? Do we need to get the wrinkles out of your sheets? Do you need to go to the bathroom? Can we give you a massage to kind of make you feel better and relax a little bit more? Maybe get you repositioned. Would you like to maybe watch some TV to take your mind off of it till the nurse gets in here with pain medication? Those are things that we can do to help them until it's time, until that nurse comes back in with their pain medicine. Doctors will frequently order medication to control and relieve pain. Now, I will tell you, belief systems with pain are a little bit different now than what they used to be. It used to be that if a person had pain, we would give them as much pain medication as we needed to take care of that pain. We wanted them to have a complete pain relief. And so if that meant giving them more and more and more medications, then that's what we did. Because the belief was nobody should ever have to be in any pain. But we are seeing a lot, of course, then there was a huge rise on addiction to pain medications and people being addicted to narcotics. And so now they're looking at, okay, are there other things we can do? So maybe we don't have to use as much pain medication. Can we give Tylenol? Can we give, muscle relaxants like ibuprofen or Motrin, to try to control some of this pain? So maybe they don't need the narcotics quite as much. Can we get by with doing massages and relaxation techniques and try to help them get through this hump of pain without having to give them as much pain medication as we used to? It used to be I would give you pain medication, and if that didn't take care of it, I'd call the doctor and get you more pain medication. That didn't take care of it, I'd call and get you something else ordered and give that to you. And we're finding that maybe some people, and especially if it's a chronic issue that a person has, like arthritis, they're always going to have it. Should our goal be 100% pain relief or good pain relief that they can still have a good quality of life, but hopefully not so much that we're going to get them addicted to something? One of the concerns with pain medication is a lot of the pain medications cause orthostatic hypotension. Orthostatic hypotension. And we talked about that when we talked about vital signs. It's where that blood pressure drops when a person goes from a lying position to a standing position too quickly, and the blood drops down out of their head, down into their legs, and they get dizzy and they get lightheaded, and it becomes a fall risk. So when people are on pain medications, some people get nauseated. That's true. Some people get what we call respiratory depression, where their breathing, actually, if they're getting a lot of narcotics, their breathing slows down, and that can be really dangerous, and sometimes their breathing can even stop. In the hospital, like after someone's had surgery, if they're getting a lot of pain medication, we actually put them on an apnea machine, so if they start breathing too shallow or too slow, it'll start alarming at them, and it wakes them up, and then it makes them and then they know to take deeper breaths. But one of the big things that we're really concerned about in the nursing home, and some of these people are getting just, they have chronic pain issues, they're getting routine medications on a kind of a routine basis, is orthostatic hypotension. They have our elderly population has a problem with this anyway. So now we're talking about they've been given narcotics in addition to that. That's going to be a big concern. So keep that in mind. They're going to be more of a fall risk when we get them up. Now, guided imagery is kind of a really nice technique, and you can actually go online and find some scenarios for guided imagery, but you basically try to describe this beautiful scene to them. So you tell them to close their eyes and just take some nice, slow, relaxing breaths, and then you try to, if they like the ocean, for instance, you're going to be, okay, you're on a nice, warm, sandy beach, and there's just a light breeze so you don't get too hot. And you hear the sounds of those waves just gently lapping up onto the ocean. I mean, you describe this really beautiful, peaceful scene to them, and so they can start visualizing it in their mind. And a lot of times that it's very beneficial. It's very relaxing for them, helps kind of take their mind off of that pain that they're having. Another thing that can happen is when we talked about heat and cold, for instance, when we were referring to heat and cold issues in one of our classes. Cold, for instance, if a person has heat, if a person's having pain, and let's say they're asking for a heating pad, sometimes warmth, okay, can dilate the blood vessels and improve blood flow to that area. So maybe they're asking for a heating pad. We can check in with the nurse and see if that's okay to give them something, okay, like a heating pad. Because some people, they may not want them to have it. Some people might be okay. But that might be something to help promote comfort. Another thing is ice. So with ice, for instance, we said that constricts blood vessels, very common when a person has swelling to an area. But you guys, you have heat receptors, cold receptors, and pain receptors in your skin. And so let's say you put ice on an area. After a while, your pain receptors, instead of saying, I hurt, I hurt, I hurt, it's going to say, I'm cold, I'm cold, I'm cold. Okay? But it's going to break that pain cycle that the person got in. So ice is a really great tool as well for temporary, like pain issues, especially chronic pain issues, knee issues. Ice works very well. Heat works well for muscular issues and for like lower back issues. Sometimes that's very beneficial as well. So when we so that's pain we were talking about. We also said rest is very important. So rest means to be calm and at ease, and you promote rest by making sure physical needs are met, safety and security needs are met, meeting love and belonging needs, and meeting a person's self-esteem needs. And when a person's physical needs are met and they feel safe and they feel like they're cared for, they tend to be more restful. Okay, they tend to be more at ease. Sleep is a basic need, but I would prefer you not do it in class. Okay, it lets the mind and the body rest. It gives your body a chance to recharge. Okay. And so vital signs tend to be lower with sleep. So when you're taking vital signs at nighttime, like let's say you have to wake a person up during the night to take vital signs, we would expect them to be lower than we would during the middle of the day after they've been active and walking around and moving around and stuff. So vital signs tend to be lower with sleep. Tissue healing and repair. Okay, so tissue healing and repair happens a lot during the rest phase. So it is very important when people have had surgeries, when they've had trauma to the tissues, that we give them good periods of rest so their body can heal and repair itself. Sleep lowers stress, it lowers tension, and it lowers anxiety. And the person tends to regain mental alertness. Okay, you can recharge and get more energy and more mental alertness. Now, some people have what we call a circadian rhythm, and your circadian rhythm is your sleep-wake cycles. And everybody's is a little bit different, and you will tend to find what works best for you. And if you're taking care of a resident in a nursing home that's living there for an extended period of time, you're going to find what works best for them, what their cycle of sleep and wake cycles are. As far as how much sleep does a person need, it really will depend on their age. Most experts believe regular sleep patterns are more important than the actual hours slept. But infants generally sleep anywhere between 12 to 16 hours a day. I think when we talked about it earlier, when we were talking about growth and development, we said actually 16 to 18 hours a day for like newborn infants. But usually in that first year of life, around 16 hours is pretty typical. School age, we're usually going to see around 9 to 12 hours of sleep a day. Adolescents, 8 to 10, and usually adults can get by with 7 to 8. Now, a lot of our elderly population, we're going to find that sometimes they really struggle to get 7 to 8 hours of sleep all at one time. What tends to happen with a lot of our elderly population is their circadian rhythms, their sleep-wake cycles start changing a little bit, and they wake up more during the night. And then they might need naps and stuff during the day, and that's okay. There's nothing wrong with that. As a matter of fact, there's actually been a lot of talk about enacting regulations that will make nursing homes actually provide activities at nighttime, quiet activities like movies or something like that going on. So when a person can't sleep, why do we make them stay in bed? I mean, if they're uncomfortable, if they need to just get up and move around for a little bit, why not let them? Let them go in and watch a movie for a little bit, and then maybe they'll be ready to go back to bed. So there's been a lot of talk about possibly in nursing homes getting more activities just quiet, simple activities going on during the evening hours or night hours. Now, things that can impact sleep, illness. I mean, illness and pain, obviously. If you're having pain, you might not be able to go to sleep. If you're sick, you might have a hard time sleeping. Nutrition. Now, you generally will feel sleepy after a large meal, and there are some things like warm milk, turkey, it releases tryptophan in your system, which can make you feel sleepy. But generally, they don't usually recommend that you eat a big meal right before you go to bed. Exercise is very beneficial for regular sleep, but they don't recommend it right before bed. They recommend it at least 2 to 3 hours before sleep time, that you would get your exercise in. Because when you're exercising, you're increasing your metabolism, you're increasing your blood flow, you're increasing the use of producing energy. And so that is not going to help you relax and calm down so you can get ready, so your body can start processing and getting ready to go to sleep. The environment. People generally sleep better in a cooler room, to be honest, with like warm blankets around them. But that will vary from person to person, and that's going to be an individual need that they have. There are drugs and other substances that can help people sleep, so some people do take medications to help them sleep. And if they're asking for something like that, we would need to go and tell the nurse. Lifestyle changes. So if a person is having difficulty with sleep, you generally will recommend that they decrease caffeine in their diet, especially any caffeine before bedtime. Not to exercise during the day, but not exercise right before sleep. To shut down electronics an hour or two before bedtime, so your body actually has a time to start kind of winding down and relaxing. Making sure you're in a comfortable environment, comfortable room temperature. And so sometimes just the lifestyle choices that you choose can help you with a little bit. When a person's having emotional problems, very hard to shut your mind off, very hard to sleep when you're worried about something. And so some people actually recommend having like a small book right by your bed, like a little journal or something, so if something's really bothering you, jot it down. Okay, jot it down, and that way you can just kind of get it out of your system, and then hopefully you can let it go for a little bit and go back to sleep. Sometimes if I've got a lot going on, I'll wake up in the middle of the night. It's like, oh my gosh, I have to do such and such, and then I start worrying about it, or I start thinking about it. It's like, just jot it down, and that way you won't forget the next day. Okay, you won't forget because it's written down. So some people recommend just having like a little journal right next to your bed. Some treatments and therapies can impact sleep, so depending on what is happening with the person. But sometimes just a really good massage. I have worked at some places where they have actually had it a policy that we will give our patients back rubs at night, because it helps not only promote circulation, it helps promote relaxation as well. So signs and symptoms of not getting enough sleep, of having a sleep disorder, well, that look says it all right there. I mean, you just don't feel good. When you haven't had enough sleep, you feel tired and cranky and grumpy. and it's just hard to feel happy and to just be able to function on your best optimal level when you're tired all the time. So sleep disorders involve repeated sleep problems. So insomnia is a person who can't fall asleep or can't stay asleep. Some people fall asleep really well, but then they wake up and they can't get back to sleep. Or they wake up early, like 2 or 3 in the morning, can't go back to sleep. Okay, that would be insomnia. And then they just lay there, I've got to go to sleep, I've got to go to sleep. And then that just makes it even worse. Sleep deprivation is when their quality of their sleep is so poor that they're having a hard time functioning the next day. And sleepwalking is when the person leaves the bed and starts walking around. And I am going to say, if a person starts sleepwalking, please don't startle them awake. You want to just kind of try to guide them gently back to their room. Don't turn on bright lights. Try to help them, just talk to them very softly. Try to guide them back to the room. Try to get them to go back to bed without startling them awake. They'll usually do a little bit better. As far as things that we can do, as far as promoting sleep, generally the nurse is going to assess the sleep patterns, but if we're seeing issues with their sleep cycles, we do want to let the nurse know in case they haven't noticed it. Follow the plan of care if they have a plan of care to help promote their sleep, and our observations of how that person slept. We would want to pass that on. So to promote sleep in a hospital and a nursing home, one thing we can do is we can close windows and curtains at night. So windows and the curtains on the windows in their rooms, we want to shut them so there's not a lot of lights coming into the room. If the person's in a semi-private room, there's 2 people in that room, we want to pull privacy curtains so there's it's dark in between the 2. We'll reduce overhead lighting. If we need to provide night lights, we can at the bedside table or near the bathroom, but we want to keep the room right over their head, obviously, and right in that area nice and dark. Closing the door. Now, if this is a resident you're going to have to go in and check on frequently, you might want to leave the door cracked open a little bit so you're not having to open and close it each time, because sometimes that wakes them up. So you can talk to the resident in the evening and see what they would prefer, to have it completely shut or to leave it partially open, so you can kind of peek in and make sure they're doing okay without having to wake them up. I know we normally not go into a room, but when you're working night shift and you think your resident's sleeping, we can actually just kind of step in and just kind of take a peek at them, make sure they're doing okay. Cartwheels. So, we try to decrease activities at night. We try to make only do essential activities at night, so we're not waking them up unnecessarily. And carts going up and down the hallways, they can get really noisy, so we want to make sure we're trying to avoid that. Wearing rubber-soled shoes is a great idea. And pay attention to conversations. You guys, I will tell you, when they do like patient satisfaction surveys to people in the hospital, how did you like your care? What did you think of it? And the biggest complaint they get continuously is, it's so noisy at night, you can't sleep. They're constantly waking me up. Well, if you're in a hospital, I'm sorry, but if you're in a hospital, you're there because you're really sick and you need care even during the night. So sometimes you're going to get woken up. I mean, I'm sorry, but you are sick. You're in a hospital. But when the person isn't getting specific care, when you're talking about a nursing home, yes, you want to peek in on them, make sure they haven't climbed out of bed, make sure they haven't fallen, make sure they look like they're breathing okay. But we don't want to constantly be waking them up. And so when we're out at the nurse's station and we're talking and laughing and it's quiet and there's nothing going on, those sounds will echo all the way down the hall. And so we really want to pay attention to that so we don't wake these people up. Okay, so as I mentioned, comfort and sleep, really, really important for good health. You just don't feel good when you don't get any sleep. And it's hard to heal and it's hard to get better when that happens. So we always want to try to promote rest for our residents as much as we can.